Assalamu alaikum wa rahmatullah. Good evening, everyone. Thanks for joining us today in our second webinar in the Young Leader Forum series. Today's theme will be around thyroid disorders. And before we start, we'd like to extend our thanks to Servier for their unrestricted support to this activity. And there are also some housekeeping announcements just to let everyone know about. That this webinar also is live streamed in our in the Society YouTube channel. So in case you log off or in case you want to join later, you can join through the YouTube channel, and there will be a form to fill later so you can get your CME accreditation. Also, the webinar will be available on-demand webinars in the EDES Institute websites. And this activity is already applied for a CME accreditation. Please don't forget to place your question in the Q&A section. And please just highlight the speaker name for whom you are directing the question. And without further delay, we have today 4 talks, and we'll start our first talk, which is around the role of radiofrequency ablation in thyroid nodules. And our speaker is Dr. Nada Ben Hrez. Dr. Nada is consultant endocrinologist at Tawam Hospital and assistant professor at UAE University College of Medicine and Health Science. She completed her training in endocrinology in University of Ottawa, Canada, and she is also certified by the American Board of Lipidology. Dr. Nada, thanks for being with us, and please do share your presentation, and you can start.
Can you see my slides?
Yes, we do.
Okay, thank you very much for the nice introduction. Today, my talk will be about the use of image-guided ablation in benign thyroid nodule. So my objective is overview the different modalities of image-guided thermal ablation, review the evidence of thermal ablation, highlight the important contents in the TA guidelines, thermal ablation guidelines, demonstrate some of the clinical cases from the Tawam Hospital. So I don't have anything to disclose. As we know, thyroid nodule is a common disorder in adult population. Prevalence reach up to 50% in female and 30% in male by ultrasound diagnosis. Most lesions are cytological benign, but it can cause some of local symptoms, which maybe do not need any treatment, but some of it can cause some of pressure symptoms, cosmetic concern, and some of it can develop subclinical or overt hyperthyroidism due to the autonomous function of the thyroid nodule. So the patient needs a solution, and usually they need this nodule to be out, but they don't like to get this scar. So what the option here? Currently, we have the development field in the thermal ablation technique, and it can be considered in those cases. So less invasive than surgery, it's cost and risk effective, improve local symptoms, and can shrink benign nodule without causing any hypothyroidism or scar. So what it is, what's the percutaneous thermal ablations? So it is irreversible nodule damage induced by increase in tissue temperature, selectively can destroy a predictable area of the nodule while sparing the surrounding normal tissue. So there is a lot of since decade, there is a lot of publication, there is a lot of the consensus, but there is no any formal guidelines until 2020, when the European Thyroid Association, they published their first clinical practice guidelines, and it is the first international guidelines for thermal ablation of benign thyroid nodule. So in this guidelines, we can see, so who's those patients who I can send them for the thermal ablations? In recommendation one, those adult patient with benign thyroid nodule that can cause pressure symptoms. So the patient, yes, they need to have diagnosis of benign thyroid nodule, either by a clear ultrasound. If you see it, it's clear cystic, so you know that it is benign, or a sphingiform, so that will be fine. Otherwise, you need to apply fine needle aspirations. Then the patient, you cannot do it for asymptomatic patient. They need to have some of symptoms, pressure symptoms, or patient is concerned have some cosmetic symptoms. Patient decline surgery, so those be a candidate for thermal ablations. Again, some of important things in the guidelines, we recommend against the use of thermal ablation for asymptomatic lesions. And before thermal ablations, we need to confirm a benign cytology, as I mentioned, and patients should be carefully informed by oral and written before we did this procedure about the efficacy and side effect and therapeutic alternative, which it is available. And we need to look for any contraindication for this thermal ablation, especially if the patient have previous scar in the neck or they have the nodule close to the critical structure. No definite nodule volume cut off to refer these patients. And thermal ablation should be mainly considered for patients with nodule with maximum diameter of 30 or more millimeter that keep growing when you see it by follow-up ultrasounds, and complaining for sure for some of the local discomfort from this. Another point in the guidelines, so after we apply this thermal ablation, how fast we can go for the first ultrasounds? Usually we need 3 months to wait to see the effect. We can also do some intermediate terms, 6 months and 12 months. We advise to do some of biochemical like TSH and ultrasounds evaluation is recommended. Long-term follow-up monitoring is suggested in the absence of symptoms every 1 to 2 years in order to reveal the regrowth and to early detect of the regrowth. Prolonged regular biochemical follow-up is not warranted unless there is an autonomous function of the thyroid. Long-term ultrasound follow-up is appropriate because of the part of this lesion can regrow after 3 to 5 years and need additional thermal ablation or surgery. So what the definition of regrowth after treatments? Usually we say there is a regrowth if the nodule volume increased by more than 50% over the smallest recorded volume. Different criteria have been used to define nodule regrowth after thermal ablation. So that's why resulting in variable 3-year recurrence rates, you can see a variable range from 5 to 24%. What the main predictive factor for recurrence for these patients? So usually if you start with large initial size, functional autonomy, low applied energy by one of the procedure which you will use, incomplete ablation of the marginal areas of the nodules. Those are the different modalities for thermal ablation treatments, which it is currently available: laser thermal ablation, radiofrequency ablation, microwave ablation, high intensity focus ultrasound. It's very rare in some only center. It's a very advanced computerized ablations, which it is very few center which they have it so far. If we want to compare between those modalities by time, for example, we can see like the quickest one is the microwave ablation from 10 to 20 minutes. And then we have laser and radiofrequency ablation from 15 to 30 minutes. Radiofrequency can extend to 40 minutes. The high intensity frequent ultrasound, it's can extend up to 60 minutes. For the contraindication for radiofrequency ablation in pregnancy and pacemaker and cystic components, we're not advised to do it in the by using high intensity frequency ultrasounds. So what the evidence which we have to inform our patient about this thermal ablations? and what we know so far. So first I will start with the laser thermal ablations. There is a randomized clinical trial doing by applied laser ablation versus thyroxine therapy or just a follow-up for those patients. We have 3 groups, as you see here: laser ablation group, levothyroxine suppression treatments, and follow-up group. And we can see here that nodule volume decreased by more than 50% is the highest in the laser group, the first group, by 33.3, while it's 0 in the thyroxine suppression therapy and in follow-up group. Also, worsening of symptom is none of the patient in the laser ablations, and improvement of symptom is 81.2% in the laser ablation, while in thyroxine suppression only 13.3 and 0 in follow-up group. And for symptomatic, it's 47.6 patients still symptomatic in the laser, while they are 76 and 90 in the other group. Another also 3-year multi-center prospective randomized trial. We can see here 2 group, 100 patients with laser ablations and control group 99 people. And we can see starting from 6 months, the nodule volume reduction continue in 12 months and 24 and remain up to 36 months. There is a significant nodule reductions. And another 12-month trial demonstrate an 84% mean volume reduction in the laser ablations in those 45 patients. Another also, we can see that it is stable, like up to 51 to 58% mean volume reduction up to 36 months. And only minority, like 5 to 9% of treated nodule exhibit significant regrowth within a 3-year follow-up. Outcome for the there is a retrospective multicenter study after a laser ablation. We can see relief pressure by 48% versus 10%, and cosmetic symptoms 86% versus 8% in control group. For the complications, we can see in this study with 1,531 patients that 0.5% rate only for both minor and major complications. Now we'll go for the next thermal ablation, which it is radiofrequency ablations. And again, it's a very good volume reduction. We can see over 5-year retrospective study, it's reached up to 67% volume reduction. And for the complications wise, we see here for major complication, it's 1.4%, and minor complication, it's 1.9% in a study of 1,459 multi-center study. And again, if we want to see the complication of radiofrequency in benign thyroid nodule, maybe the main complication, as we see it from here, is a pain in the side, and that which it is the main complications for this procedure. Number 3, microwave ablations. Again, consistent with the same meta-analysis, volume reduction very significant, 74% in 6-month follow-up and 89% in 12-month follow-up. For microwave ablation, it says maybe this which I can find like it's the higher risk of major and minor complication than the other 2 which I present, the laser and radiofrequency ablation. But again, it is not very high or significant, but higher than the other 2. For the high intensity focused ultrasound, there's very little evidence because it's a new practice, but we can see here that 6 retrospective and prospective study with a follow-up ranging from 3 to 12 months, the mean volume reduction is ranged from 48.8 to 68.8%. Another study comparing the laser and radiofrequency ablation for treatments of benign thyroid nodule, we can see that mean volume reduction at 6 and 12 months were not statistically different between both procedures. But in another, we can see that there is moderate superiority of radiofrequency in terms of nodule volume reduction, and that has been seen in 2 systematic reviews covering total 184 and 1,186 patients. So the first systematic review, as we see it here, a greater 6-month mean volume change from 77.8 versus 49.5 was reported after radio frequency ablation as compared to laser thermal ablations. And this is the second systematic review, similarity to the first one. Its meta-analysis at 12 and 24-month radiofrequency ablation shows greater volume reductions than laser therapy by 75 versus 52% and 87 versus 45, respectively. And we can see here like great comparisons and the reduction in both, but it's more in radiofrequency ablations. In prospective non-randomized multi-center study, same as single study center, also in 1,252 patients treated with microwave ablations or radiofrequency ablation, we can see that the two techniques appear to be similarly effective with non-significantly greater nodule volume reduction at 6 months in radiofrequency ablation group. Microwave was also associated with slightly higher complication rate than radiofrequency ablations. So back to the guidelines, based on a direct comparison study and balance between efficacy and side effect, the laser thermal ablation and radiofrequency ablation are recommended as the first line thermal ablation treatments modality. And based on study to date, microwave ablation should at present be considered as a second line thermal ablation procedure in patients who are not suitable for or decline other thermal ablation procedure or for participant in protocoled clinical study. Based on its lower efficacy, higher cost, and limited reported trial evidence as compared to radiofrequency and laser, the high-intensity frequent ultrasound should be considered only for selected nodule in patients who are not suitable for or decline other thermal procedure and for participants in protocol study. In multi-center goiter, due to lack of evidence of efficacy and expected need of repeat treatment, thermal ablation should be restricted to patients with well-defined dominant nodule or those who are not candidate for thyroid surgery or radioactive iodine treatment as a palliative therapy options. So for regarding the high intensity focused ultrasound, because of higher cost and complexity as compared to aspiration, so thermal ablation procedure are not recommended as a first line, as we mentioned, and laser and radiofrequency should be considered therapeutic option for cystic lesion that relapse after ethanol applications and for those that would remain symptomatic due to large residual solid component. So technical efficacy defined as those for patients who have autonomous function of the thyroid. Usually how we define the technical efficacy, it is for restoration of normal thyroid function associated with equal to 80% or more reduction of initial volume is around 50% at 12 months. The larger the nodule, the poorer the likelihood of achieving durable control of thyroid function, because we know that the relation is inversed here. So the smaller you start, the bigger volume reduction you will have. So again, we have a lot of evidence supporting using thermal ablation in autonomous thyroid functions. nodule. So thermal ablation may achieve near complete normalization of serum thyroid hormone in a small size, less than or equal to 10 ml for autonomous thyroid nodule, accompanied by substantial more than 80% volume reduction, while thyroid function is controlled only in small fraction of larger autonomous nodule. There are no relevant, for microwave ablation, there are no relevant study specifically address the efficacy and safety of microwave ablation for treatment of autonomous thyroid nodule. Depend on that. So in the recommendation 15, we recommend again thermal ablation as first-line treatments for large autonomous thyroid nodule due to the low rate of restoration of normal thyroid function. Thermal ablation should be considered only for patients who decline or are not candidate for radioactive iodine therapy or surgery. Thermal ablation should be considered in young patients with small, autonomous, and incomplete suppressions of prenodular thyroid tissue due to the higher probability of normalization of thyroid function and the advantage of avoiding irradiations and restricting the risk of late hypothyroidism. Treatment with combinations of laser plus radiofrequency ablation and radioiodine may be considered in selected patients with large autonomous thyroid nodule that cause local pressure symptoms in order to achieve a more rapid volume reduction and use of lower radioactive iodine activity on those patients. So here I will show some of cases from our division, and thank you for Dr. Effendi to share some of his case, and Dr. Jamal, the intervention radiology in our hospital, to send some of picture. So this is one of the patient who present with autonomous thyroid function, and he have very big cystic nodule, and this is the after applying microwave ablation. It's 20 weeks post microwave ablation, and you can see how it is solving his big nodules and without any scar. And this second patient is a 45-year patient with 4 centimeter right cystic right thyroid nodule. Again, she was offered a surgery, but patient refused. And she was, she's thinking she don't want to have this scar in her neck, and that's why she think between surgery and microwave ablation. And then you can see here the intervention in radiology in our hospital. And first, we need to empty all the fluid and aspirate the cyst. After that, the high temperature modality, either by this microwave, you can destroy the remaining nodule, which it is there. So it's only 4 minutes, 444 seconds. Power is 30 watt, which he used for this. And this is the post-microwave ultrasounds. And you can see that 3-month post-microwave ablations. 4-week post-thyroid ablations, and this is another case used radiofrequency ablations. So goodbye to the scar, and by using this, but we need to select a good candidate for this procedure. And thank you very much for your listening.
Thank you so much, Dr. Anada. Thank you so much for the elegant lecture and being on time. So we'll move now to the second talk, which is thyroid cases in pregnancy. And our speaker is Dr. Balsam Bouhliqa, who is consultant in endocrine and diabetes division at Prince Sultan Medical Military City. And she is the program director of the Adult Endocrine Diabetes Fellowship Program at the same institution. Her talk is recorded, but hopefully she could join us in a Q&A session. So please do place your questions, and please start the recorded video.
Good evening, everybody. I've been invited to give this talk and about cases of including hypothyroidism in pregnancy. So I'll start my talk. So I'll be presenting common cases that a lot of us see in clinic. So today I'm going to be talking about the physiological changes during pregnancy. We're going to talk about the latest published guidelines, 2017, American Thyroid Association guidelines in management of thyroid disease in pregnancy. Our focus is going to be mainly about patients who are diagnosed with subclinical hypothyroidism in pregnancy and autoimmunity in euthyroid women. I'm also going to share with you some of the newer data published after the release of the guidelines and how it may change the current practice and hopefully, as the guidelines are being reviewed now, change the recommendations in the future. And then I'm going to end up with a summary. So let's start with our first case. Our first case of the day is 34-year-old female who is she was pregnant, first pregnancy. She's 14 weeks pregnant, and she is referred by her family doctor for evaluation and management of her thyroid function test. She is asymptomatic, and she does have a strong family history of hypothyroidism in her family. Examination is basically normal, is unremarkable. And when you look at her thyroid function tests at 6 weeks gestation, her TSH was 4.5, and you can see that's clear. That's within the normal reference range for non-pregnant individuals. At week 12, her TSH is even higher at 4.8, with a free T4 level of 15. So questions with regards to this case. This case are what are the normal reference ranges for pregnancy? How can this affect the pregnancy and the fetus? What is the role of levothyroxine replacement? And what does the evidence say? And what are the current recommendations? So let's start first with physiology. So what are the changes that are expected in pregnancy, and how does that affect our labs? What are the timelines that these changes are expected to happen, and why are we so concerned about thyroid hormones and their impact in pregnancy? So when we look at the physiological changes in pregnancy, and I want you here to focus on this diagram or the cartoon, you see it all starts with the placenta that secretes HCG hormone, which is pregnancy, that I always tell my patients, sorry about that, that this is the hormone that gives you a positive pregnancy test. It's usually produced by the trophoblasts, the corpus luteum, the trophoblasts in the placenta. So the HCG plays two important roles. The first thing it does, it mimics TSH. So it goes to the thyroid gland and it stimulates production of both T4 and T3, resulting in a total increase of T4 and T3 production, as well as the second function HCG does, and the placenta, of course, it increases the production of estrogen. And estrogen is a game player, as a huge game player in this physiological changes. As we all know, estrogen increases all globulins in the body, including thyroid binding globulin. So this, of course, leads to reduction in the free T4 and free T3, but an increase in the total inactive T4. So the end result is going to be increase in the maternal total T4 and T3, and there is going to be a decline in the free T4 and the free T3 as pregnancy advances. So as we mentioned, TSH is going to be suppressed, especially in the first trimester, owing to the HCG activity in especially in the first 10 weeks of pregnancy. And there is an increase in the total T4 and the thyroid binding globulin that continues until 20 weeks of gestation. With that, there's a progressive drop of free T4 levels as pregnancy progresses. So keep in mind that these changes are dynamic. So week by week, you're going to see different changes are expected to differ. I drew a mark here showing you the importance of the 20-week mark, whereby most of the physiological changes settle down and you reach the steady state with most of the hormones. And why is this important? Because we know from research, both animal and human studies, that thyroid plays an important role in the development of the brain and the placenta of the neonates. So what happens if a mother is severely hypothyroid? So this is a classical teaching of cases with severe hypothyroidism, whereby you have severe iron deficiency, severe intellectual issues, but we don't see that anymore. However, I found this study, which I found was really interesting to talk about, looking at women who are diagnosed with severe hypothyroidism early in pregnancy. And if you compare them to controls who are not on treatment or who have normal thyroid function tests, they usually do well towards the end of pregnancy, with no differences if they are managed appropriately during pregnancy. Again, so what do we commonly see in practice? What we usually see is subclinical hypothyroidism. It's much more common than we see overt hypothyroidism. Cases of subclinical hypothyroidism have been linked with multiple adverse pregnancy outcomes, including a pregnancy loss, abrupted placenta, and neonatal death. Like in this meta-analysis, looking at more than 4,000 women with subclinical hypothyroidism. So how frequent do we encounter these issues in pregnancy? So overt hypothyroidism, as I said, was rare. It's estimated to be up to 0.5. Subclinical hypothyroidism, on the other hand, is really common. It depends on the population being studied and the upper limit of normal that you choose to use as defining what is normal for your TSH. So in Saudi Arabia, for example, in 2016, the prevalence was thought to be around 13%, which is a huge number of women diagnosed with subclinical hypothyroidism. So this is very common, and you will encounter this in practice. So what do the guidelines tell us? So if you go back to the 2011 guidelines, the guidelines that were published before these current guidelines, they usually had, these reference ranges were mostly based on a smaller number of women and from only one ethnicity, and these were the recommended TSH targets. However, in the 2017 guidelines, where there are larger studies, more ethnicities included in these studies, we now learn that probably the upper normal limit of TSH is higher than we expect. So the guidelines currently tell you that if you don't have a trimester-specific, population-specific reference ranges, you should use the non-pregnant reference ranges with 0.5 less than the upper normal limit, which usually comes down to 4 being the upper limit of normal. Okay, this is just to tell you how some of these studies that were included, and you can see different variable populations that were included. So this is just a diagram to show you, to show you the current recommendation from the 2017 guideline. And it looks complicated. I'm just going to keep it simple as much as I can. So in women who are pregnant, the TSH, if a woman has a TSH of more than 10, then the recommendation, everybody feels strong and confident to start treatment, and usually they have overt hypothyroidism. If the TSH is less than 2.5, most people, everybody agrees that these women should not be treated with levothyroxine. The issue happens usually in women who have a TSH level between 2.5 to 10. So the guidelines talk about TPO positivity being based on a woman's TPO status. You can make the decision whether to treat her or not. So the threshold depends whether or not she's positive or negative. So in a woman with TPO who is TPO negative, we do not usually consider treating them unless their TSH is above 4. Compared to women who are TPO positive, you may consider treating them if the TSH level is 2.5, but it is strong. The recommendation is stronger to treat them if their TSH is above 4. So just to summarize this complicated diagram so you may consider treatment if a woman is antibody positive, if their TSH is above 2.5, and if they're negative, if they're anti-TPO negative, you can consider treatment if their TSH is above 4. And if you decide to treat, the target should be always less than 2.5, and approximately you should follow these patients every 4 weeks until mid-gestation, and then at least once near 30 weeks of gestation. So what is the evidence behind this? We have a couple of interventional trials that were done, and this is a meta-analysis of all the interventional trials that were done, and this was usually women who were started on treatment between 12 and 16 weeks of gestation, and there was actually no evidence to support benefit of levothyroxine for the primary endpoint of pregnancy outcomes or the IQ of the kids. If you decide to treat, however, women, there are 2 methods. You can either use the fixed dose method, or you can dose women based on their weight. Just to answer the first case that we talked about, so TSH was higher, so this woman has subclinical hypothyroidism. If you're going to follow the guidelines, you may consider treating her as her TSH is above 4, whether or not she is a TPO positive. Okay, moving to the second part of the talk. So this is a 32nd case. This is a 32-year-old female who has had 3 miscarriages. Her TSH was within normal, but she has positive TPO antibodies. She's currently following up with her gynecologist, who sent her for your recommendation with regards to her positive TPO antibody. This is very common. You see it a lot now, the talk of thyroid antibodies. So talking about autoimmunity and pregnancy, anti-TPO, anti-TG are quite common. In pregnant women, up to 17% of women have positive antibodies. There have been clear associations between having these antibodies and pregnancy losses, and even preterm delivery. The mechanism is not fully understood. These antibodies could simply be a marker of other autoimmunity contributing to the pregnancy loss or the preterm delivery, or it could be that these women who have positive antibodies tend to develop hypothyroidism in pregnancy, as I showed you, because of the physiological changes and the increased demand on the thyroid gland, so they are more likely to develop hypothyroidism. There have been proposed treatment for women who are euthyroid but antibody positive, like steroids, selenium. I'm not going to talk about these today. In general, the guidelines do not recommend the treating women with these 2 options. However, thyroxine has been studied, and there are recommendations about them in the guidelines. So I'm going to go through levothyroxine therapy. So I'm going to start with the guidelines. So the guidelines do recommend that in women who had prior history of pregnancy loss, you may consider starting them on 25 to 50 micrograms of levothyroxine. However, they do mention that these are weak recommendations with low quality evidence. Since the publication of these guidelines, we have had a couple of interventional trials that I'm going to talk about today. So one of them was published in 2019. It was in the New England Journal of Medicine. It was looking at around 950 women who were started on levothyroxine once a day before conception, and the primary endpoint was live birth at 34 weeks of gestation with a few secondary outcomes. And basically what the study showed that there was no significant difference between the two groups who were treated and who were not treated with levothyroxine in pregnancy. The second trial that was published more recently in 2022 in the Lancet, the Lancet Diabetes Endocrinology. This was also a trial looking at the T4 Life randomized control study. They looked at women who had TPO antibody positive, who had more than 2 miscarriages with normal TSH. And the intervention was to give them levothyroxine based on their weight from preconception till the end of pregnancy, and primary endpoints were live birth. However, this trial was stopped prematurely due to slow recruitment, and the end conclusion was that there were no differences between the two groups, whether or not a woman received levothyroxine or did not receive levothyroxine. So just to answer the second case, so the guidelines do recommend starting a small dose of T4. However, this is weak. This is based on weak evidence, and this is a weak recommendation based on low quality evidence. And this may be changing in the future as the new guidelines come out. If you decide not to treat a woman who has TPO antibodies positive, the recommendation is to follow these patients in pregnancy, especially every 4 to 6 weeks, especially before 20 weeks of gestation, as I showed you before all the changes have happened, because they are at risk of developing hypothyroidism in pregnancy. And to use the same cutoff points that we talked about in the first case. So just to summarize my talk today, that there are physiological changes that happen in the whole thyroid pool, leading to increased requirements of thyroxine, especially in the first half of pregnancy. Hypothyroidism carries a risk on pregnancy and neurocognitive development of the offspring, particularly in women who are antibody positive. The recommendation from the guidelines, 2017 guidelines, is to use TSH specific, range specific, and trimester specific reference ranges. If not available, you can use 4 as the upper normal limit, or at least you can use your upper normal limit for non-pregnant population. The cutoff for treatment depends on whether or not a woman is antibody positive. And once started, a woman should be treated to target TSH level of less than 2.5. However, as I have mentioned, that a lot of evidence has come out since these guidelines were released. So we may be expecting some changes in the newer guidelines that are being reviewed currently and soon will be published. So thank you for listening. I hope to join you in the Q&A sessions, and thank you for listening.
Excellent talk. So we will move to the third talk then, which is titled "What are the pitfalls in thyroid function test?" And our speaker would be Dr. Fawzia Rashid, who is an endocrinologist in Dubai Hospital. Also, her lecture is recorded, and she will join us in a Q&A session. So please do place your questions. Please do start the lecture.
Good evening, everyone. Thank you so much, Dr. Rhea, for your kind introduction. So today I'll be presenting what are the pitfalls in thyroid function test. So without further delay, we will move towards our topic of the presentation. So by the Cambridge Dictionary, what is the meaning of the pitfall? It defines as likely mistakes or problem in a situation. So where does it fall into our topic today? That what could be the possible mistakes in understanding of thyroid function test, or how we can encounter a problem in dealing with a clinical situation. So thyroid function test, as we all know, is one of the most commonly requested laboratory investigation across the primary and the secondary care sector. And most of the times, again, very straightforward to interpret, and we diagnose usually that the patient is euthyroid, hypothyroid, or hyperthyroid. However, there is still a subgroup of TFTs which doesn't make much sense to the treating physician, either because they don't match with the clinical picture of the patient or they appear incongruent with each other. So what are usually the laboratory tests we order to assess a status of thyroid in a patient? Some of the institute only prefer to offer the TSH concentration, while some coupled it with the free T3, T4 concentration. Still, some labs do use total T3 and T4 as well along with their panel. However, it must be noticed that free and total may not be concordant with each other. And to take a tour of pathophysiology and to understand better the hypothalamic pituitary thyroid axis, I want to do this exercise that it will help us to understand how the thyroid functions work in such an intricate way. If you see here that the hypothalamus, basic organ which secretes thyroid hormone releasing hormone TRH, and which work on the pituitary gland, which secretes TSH. This tropic hormone works on thyroid gland and stimulates its growth, cells, and in turn secretes T3 and T4 hormone into the circulation. This T3 and T4 negatively goes and in turn by negative feedback loop inhibits the secretion of TRH as well as the TSH in the pituitary. Here we notice that I'm mentioning the beta and the alpha receptors. What does it mean? Actually, the gene transcription for thyroid receptors is by the alpha and beta, which are further subdivided into the alpha 1, alpha 2, beta 1, beta 2 receptors. And some organs have abundance of alpha receptors, while the others, for example, the liver, kidney, pituitary and hypothalamus have more predominantly beta receptors. It has clinical significance when we talk about the resistance of thyroid hormone. But to understand that once a thyroid hormone goes into each organ, it goes via these receptors, and after the entry into each cell, it has to convert into T3 via the enzyme deiodinase. T3 can also a small fraction directly absorb into the cell via the MCT8 receptors. And after the entry into the cell through the coenzyme and retinoid X receptor, they work and change into the DNA happens. So the TRE, which is thyroid receptor element, and thyroid hormone executes its function. So if you see this whole pathway, it is very tightly regulated, and that's why the patient usually have in a lifetime a particular range of TSH. And usually they don't deviate much from this range. And to understand it better, if you see that the negative and the positive stimulation loop works in a very refined and very tightly regulated way, and whenever the T4 concentration is high, TSH has to go down. So that's why it is called negative log linear relationship between the serum free T4 and TSH concentration. And here, if you see that once it is released and it goes to the liver after the sulfation and glucuronation, it passes out for excretion, and some of that is still reabsorbed through the entire hepatic circulation and goes into the circulation and exerts its work for the cells. So another point to understand is the transport of thyroid hormone. Another important thing is that thyroid hormone is very strongly bound, and most of the fraction, like 99.97 of T4 and 99.7 of circulating T3, is bound any of the three binding protein, a globulin part, which is known as TBG, prealbumin, which is transthyretin, and albumin. And that's why it is important that we have to understand any pathophysiological condition which increase or decrease the production or alter the affinity of thyroid hormone to these protein will definitely affect the thyroid function test. This is a very important slide I adopted because it covers everything about the pitfalls about thyroid function test. So if you see in the center of this picture, this is a normal euthyroid biochemistry. A person is having a normal TSH, normal T3 and T4 level. While if you go to the upper side of this panel, you see the picture which we commonly straightforward diagnose as hyperthyroid by virtue of having suppressed TSH, increased T3, T4, and the causes above for hyperthyroid are described. If you go to the down panel of this picture, there is increased TSH along with the decreased T3, T4, which is again very straightforward, and we diagnose these cases as hypothyroidism. So on the extreme of this picture, if you go to the upper right panel, here comes a little bit of confusing picture which we commonly encounter, and we call it isolated hypothyroxanemia, because this patient have low free T3, T4 along with either normal TSH or suppressed TSH. So the most important differential here is to rule out whether the patient has something central from the pituitary or the hypothalamic deficiencies causing hypothyroidism, followed by the non-thyroidal illness or the SA interference. Into the down right panel, if you see the opposite picture of the upper one, where the isolated hyperthyroxanemia with the normal TSH or increased TSH. And there is a wide list of differential to consider in these cases of TFT's picture, including the presence of SA interference, patient is having some binding protein abnormality, abnormal affinity, psychiatric disorder, presence of the centrally acting TSH adenoma, or the resistance to the thyroid hormone. If you go towards the right side, right upper panel, the picture is again quite common in the clinical practice where the patient has suppressed TSH and in normal T3, T4. We denote this biochemistry as subclinical hyperthyroidism, and most of the causes include either the mild Graves' disease, toxic adenoma. Sometimes patient has been under treatment for thyrotoxicosis and is still lagging the pituitary recovery from it. Some drugs can also decrease the pituitary TSH secretion. And again, non-thyroidal illness and SA interference is one of the differential for this biochemical picture. There on the left down panel, the patient has normal T3, T4 and increased TSH, which denotes most commonly in the clinical context is subclinical hypothyroid, and the rare causes again to consider is the presence of malabsorption, SA interference, NTI, and the thyroid hormone resistance. So why it is all important to consider all of these parameters? Because they are common, they're not very rare. And to avoid the inappropriate treatment and to preserve our resources, we have to adopt a structured approach when the patient is requiring investigation or when we have to stop offering further investigation. So here we will discuss one by one all these structured approach. The first thing to consider is always revisit your clinical context of the patient. Always look the history again, always look the examination, look into all the potential confounding factors, which can include either patient physiology is altered, like pregnancy, age, extremes of age, is any presence of the intercurrent illness, some medications are under use. If you rule out all of these, then you consider that whether there is an assay artifact affecting these patients' thyroid function picture. And if you rule out again with your laboratory collaboration that there is no assay disturbance, then you will consider for the rare genetic or the acquired disorders of hypothalamic pituitary thyroid axis. The examples include the presence of the resistance to thyroid hormone, which is known as RTH, or thyrotropinoma, which is the TSH secreting pituitary adenoma. So when we talk about the physiological effects, number one cause of them is pregnancy. Pregnancy is a very, very important cause to consider, specifically when the patients are there. We frequently get referral as well as inpatient and outpatient for the altered thyroid function test. One of the commonest in first trimester is the presence of gestational hyperthyroidism because of the effect of HCG, which is affecting on thyroid hormone and secretes and suppress the TSH because it resembles part of the TSH. Another major changes is sometimes the decreased T3, T4 because of the increased TBG level, and total T3, T4 increase up to 150% of the non-pregnant values. And these changes exist till end of the parturition. So the reason behind all of these changes is because there is increased plasma volume, there is a rise in TBG, there is enhanced DIO3 activity, which actually helps in degradation of T4, T3 and increase the iodine urinary clearance, and also the fluctuating level of the beta HCG. Another second important thing in the patient clinical condition is to consider the presence of non-thyroid illness, which is commonly known as sick euthyroid syndrome in the medical language. It is actually a very important factor to consider because many times patients in hospital and ICU setup is called, and because of the very strange thyroid function tests, and sometimes actually it is very difficult to decide if the patient really have a central hypothyroid or this is only the sick euthyroid syndrome. Generally, it is defined by absence of an intrinsic abnormality of the HPT function, and it is considered most of the time as an adaptive changes, but there is a very ongoing debate whether this is a beneficial response in general to reduce the metabolic rate of the patient, or it is a maladaptive response, and we can give some benefit with the T4 replacement therapy. Up till now, there is no concrete evidence that therapy is beneficial in most of the patients or not. So what the common thyroid function test features we can see and why, and in any acute critical illness, patient's TSH is usually suppressed because of the pituitary shutdown, or you can say that again the secondary adaptive response. Many time in acutely critically ill patient is on multiple medicines like dopamine, dopamine, steroids, heparin. They can also affect the presence of normal TSH secretion binding, and sometimes they have competitive binding issues with the binding protein, and they detach the T4 from that. So that also changed the T4 levels. During the phase of recovery, TSH start increasing. That also give rise to discordant T3, T4 with TSH value. And TSH also inhibited by the sometimes presence of octreotide in patients, it can affect it. So we have to consider. In parallel with the extreme of nutrition, malnutrition, absorption, heterophil antibodies, patient may have some other systemic features like adrenal insufficiencies. They can also affect the thyroid function test. What are the etiologies behind this non-thyroidal illness affecting the TFTs? That it may be the hypothalamus reduced secretion from the paraventricular nuclei itself, pituitary impaired secretion of the TSH, altered thyroid hormone binding capacity in the serum. At the level of cell, there is a reduced uptake of T3, T4 to conserve the metabolic or the cellular energy, and increased degradation by the activity of DIO2 and DIO3, and reduce activity of DIO1, and receptor gene signaling expression is all altered in the different tissues level, and it happens throughout the body. And it is said that most of the pro-inflammatory cytokines mediate this action, and some studies have mentioned the reduction in the leptin levels and presence of increased endogenous glucocorticoids also works on all of these possible mechanism for NTIs. After pregnancy and non-thyroid illness, the third factor to consider in TFT fitfall is the effect of the drug therapy. It is one of the most common cause again, because multiple drugs affect at various level, which we discuss in the hypothalamic pituitary axis, from the secretion till binding and transport. So if you see, there is a big list of the medicine actually, and we have to be mindful whenever we interpret those tests in the context of the patient medicine. So some of the drugs which cause hypothyroidism, either by the inhibition of synthesis or the release, by decreased absorption of the T4, by dysregulation at the level of thyroid hormone synthesis, suppression of the TSH, they can cause destructive thyroiditis, increased type 3 deiodination, and increased T4 clearance. So if you see the number of the medicine, and most notably among them is the iodine containing medicine which inhibits the thyroid hormone synthesis. Some of the medicine like proton pump inhibitors, binders, cholestyramine, they decrease the absorption of the T4, so they can give rise to low T4 value into the serum. And many of the newer medicine which are used in oncologies and rheumatologies like biologics and tyrosine kinase inhibitors, immune checkpoint inhibitors, they also cause at various level from hypothalamic pituitary till thyroid, disturbance of the thyroid function test. There are certain drugs which affects without thyroid involvement, like by decreasing the production of thyroid binding globulins, including androgen, danazol, glucocorticoid. Some increase high level of TBGs, and by that there is increased binding of T4 and reduce availability of the free fraction of T4, like estrogen, tamoxifen, mitotane. And some they just reduced the binding of thyroid hormone to TBG, like they compete with the binding, like the high dose of furosemide, heparin, salicylates. And some medicine increase the clearance, as we saw before. And this is a very important point to consider, because if patient is hypothyroid and already on the replacement therapy, and for some reason they have started on, for example, phenytoin, carbamazepine, rifampicin, they may need to increase the dose because the metabolism through the P450 pathway is affected, and maybe their demand for T4 becomes increase in future. Some drugs cause hyperthyroidism by stimulation of thyroid hormone synthesis or release, like iodine and amidron, which is a drug which affects at all level of thyroid hormone pathway, and some by dysregulation of immune system, like alemtuzumab, ipilimumab, etc. So we have to be mindful about the drug effect on the different levels of thyroid function test and how the thyroid function test will reflect. The fourth factor to consider if you have ruled out the clinical contact of the patient is the lab assays. As we all are aware, there are multiple methods are available all over the world, and most of the institute have adopted the third generation TSH immunometric camelucent assays, and for the T4, T3, there is a direct competitive binding camelucent assay available. For the gold standard, most of the lab assays are available only to the research because being expensive. So there are presence of interference in the assay, which leads to sometimes problem in thyroid function test. For example, the TSH measurement, because being a two-site or sandwich format, so many of the antibodies directed against the different epitope can affect to the interpretation of the TSH. For example, in this diagram, this is a normal assay. If you see, this is a normal capture antibodies anchored to the substrate, and this is the detection antibody, and this is our analyte TSH. While if there is a presence into the serum of the patient of some kind of anti-animal or heterophil antibodies, which are capable of cross-linking. So what they do, they cross-link the capture antibody with the detection antibodies like this, and they will give rise to positive interference. Positive interference means this will give rise to falsely elevated level of the TSH in the results. While some are the blocking antibodies, how they work, they block the capture and the detection antibodies, and the TSH is not being read into the assay, and it gives rise to falsely low value of the TSH. So another mostly we all are aware the presence of the biotin, because some assays use the biotin streptavidin separation system, and if a patient having a high biotin level in the serum, it can give rise to spurious results. It can decrease the TSH value if the immunometric assay is used, and it can falsely increase the value in the competitive binding assay for T4, T3, and TRAPs. So if we already aware the patient is on biotin supplement for some reasons, we have to hold the supplement before ordering the test. And if the patient is on more than 10 milligram per day, we have to hold it maybe up to the 7 days to 10 days. T4 assay is also not free of interference, and multiple intrinsic and external factors can cause spurious results, like presence of antibodies, binding protein abnormalities, and heparin and other displacing agents can affect the T4. So we have to understand the key point that none of the assay is completely free of any artifact, and they are prone to interference. And we have to compare the previous result, if available, with the current result. Any divergence has to notify, and we have to understand that clinical setting is still the paramount if suspecting that what could be the reason behind this disturbed thyroid function test. And the correct reporting of interference is the responsibility of the clinical laboratory, and a single test rarely is sufficient to identify the interference. So sometimes you have to repeat the test once or twice or maybe multiple times, depend on the level of the disturbance. And it's very important to have an ongoing communication. This factor is sometimes missed in the clinical practice, but it's very important that we as a physician, biologist, and manufacturers identify if there is a persistent kind of interference to prevent any problem in the management of the patient. The rare causes after exclusion of the above mentioned factor is the resistance to thyroid hormone, which is pretty rare disease. And depending on the partial or generalized resistance, patient thyroid function test disturbs. Some people have very high TSH, some have slightly high with normal T3, T4 concentration. Same is the variance in the clinical manifestation at the level of defect. If patient has defect in particular organ only, then they will not have very generalized kind of abnormalities. The most important thing we have to consider as a clinician is to differentiate that whether the patient abnormal thyroid function test is the result of resistance or whether this is because of the centrally secreting TSH tumors. Because most of the time you find in these patients that have either high normal or grossly high TSH along with high T3, T4. So if we can take into the history about their family members, all of them will have the same feature. It goes with the resistance. If you can do the genetic study, which can be positive in up to 75 of the cases, it denotes the TH. But up till now, this is one of the most challenging feature to differentiate between the resistance versus the TSHoma. Because TSHoma again is very rare, although there is increasing report because of increased awareness and the presence of the good labs, sensitive assays, and high resolution pituitary MRI, the diagnostic rate is increasing up to the 2 to 3-fold higher than earlier. The other cause which is important to consider in binding protein abnormality, because thyroid is very strongly bound and most of the fraction is protein bound. So any deviation in the concentration or the affinity can give rise to spurious results. So there are various abnormality has been detected, some of them reported in different families and very, very rare. For example, there is an altered affinity of albumin with increased capacity for thyroid hormone, which is in the case of familial dysalbuminic hyperthyroxanemia. Some hereditary causes where the TBG actually is an excess, and some hereditary causes where the TBG is deficient. And some transthyretin binding abnormalities have been reported. Some systemic condition where there is a loss of the albumin from the globulin production, malabsorption, and effect of the drugs can also cause binding protein abnormalities. So in summary, whenever you encounter a discordant TFTs, so you always advise to reevaluate the clinical history by checking for the age. Extreme of age always have different patterns of thyroid function tests. Physiological conditions like pregnancy, which has a multitude of effect on thyroid function test. Then if the patient is on thyroxine therapy, then we have to consider if the patient is having confounding dietary factor, medication, malabsorption, non-compliance, etc. Effect of the other drugs like amidrone, furosemide, heparin, corticosteroids, TKIs, immune checkpoint inhibitors, and always see in the hospital setup specifically, but sometimes even the chronic illnesses can affect the thyroid function test, and they have a different area of the manifestation. If you have reevaluated the clinical history, again reassess the thyroid status, how the patient actually looked like clinically, if he's euthyroid, hypothyroid, or hyperthyroid, and see which of the pattern goes along with that clinical context of the patient, and rule out all the time for thyroid hormone and TSH assay interference. Always contact your laboratory, take their input, and deal accordingly if you find that this persistent pattern is observed across many patients. And then you can always investigate for rare causes like genetic and acquired disorder of HPT functions. And if you find that something is really existing, you can always refer to the specialist center. So here I will end my presentation. These are my references for preparation of this presentation. And thank you so much, everyone, for your kind attention.
Thank you so much for this extensive review. And then we will go to the fourth talk today, which is titled Nuclear Imaging in Thyroid and Parathyroid Disorders. And our speaker, Dr. Hidayat Al-Ansari, who is consultant radiologist and chief of nuclear medicine at the Imaging Institute of Cleveland Clinic Abu Dhabi, and the medical director of Cleveland Clinic Abu Dhabi Al Ain branch. Dr. Al-Ansari has extensive expertise and specialist interest in PET-CT, nuclear medicine, CT colonography, and MRI enterography. The talk is yours, Dr. Ansari.
Good evening. My name is Dr. Hidayat Ansari, and I'm the chair of nuclear medicine at Cleveland Clinic, Abu Dhabi. Today, I'm going to talk about radionuclide thyroid and parathyroid imaging. Thank you, organizers, for this opportunity, and thank you all for staying back so late to listen to this lecture. The objectives of my talk are to discuss the role of radionuclide imaging in thyroid and parathyroid disease, review nuclear imaging spectrum of different benign and malignant conditions associated with these, list and review common isotopes utilized in endocrine imaging, identify indications and applications of PET-CT isotopes, understand both limitations and pitfalls in nuclear imaging of thyroid and parathyroid diseases. Firstly, let's talk about thyroid nodules. Thyroid nodules are by far the commonest finding which is seen in radiology imaging. So in this case, you have a thyroid nodule in relation to the left lobe of thyroid gland. This is a routine ultrasound study. How does it look on an nuclear medicine isotope study? This nuclear medicine study is performed with the technetium-99. You can see that the right lobe of thyroid gland has uniform uptake. However, the left lobe appears as a thin sliver of thyroid tissue with what looks like a space-occupying lesion or a photopenic abnormality in relation to the left lower pole of the thyroid gland. And this is the pinhole image demonstrating the same. And this is a SPECT image with both anatomical and functional fusion, and you can see that there is a nodule here in relation to the left lower pole of thyroid gland, which is displacing and attenuating the thyroid gland here. And this is an example of a thyroid nodule. Thyroid nodule is extremely common. They are in a range of in between 4 and 7% with a female predominance of 4:1 ratio and can be seen on both technetium-99 scans and I-123 thyroid scan. Particularly, the studies have shown that in an I-123 thyroid uptake scan, up to 15 to 20% of cold nodules are proven to be malignant. What are the risk factors of cancer in a cold nodule? Prior radiation exposure to head and neck region, family history of thyroid cancer, particularly if the patient is a child or older than 60 years of age, and if nodule increases in size with thyroid hormone suppression, these are all considered as risk factors of cancer in cold nodules. This is another example you can see on the ultrasound study. You have a large nodule in relation to the right lobe of thyroid gland. It has heterogeneous echoic texture with focal hyper and hypoechoic areas. If you look at the same nodule on the nuclear medicine study, you can see that there is intense increased activity in the right lobe of this thyroid gland in relation to this nodule, and all the rest of the activity across the thyroid gland is completely suppressed. And this is a case of toxic adenoma. Up to 5% of solitary palpable nodules are related to toxic adenomas. They contribute to 10% of patients in thyrotoxicosis. And if the nodule size is greater than 2.5%, they usually result in hyperthyroidism. They can be single or multiple. How about this case? You have a heterogeneous uptake across the entire thyroid gland, some foci of increased uptake, some foci of decreased uptake, and this is just a multinodular goiter with multiple thyroid nodules. How about this case? You can see in the region of the thyroid bed, there is absolutely no activity there. So what are we looking at in a case where there is no uptake across thyroid gland? This is a case of subacute thyroiditis. How about this case? You can see that there is diffuse increased activity across the entire thyroid gland with almost a butterfly pattern. The relative and absolute activity across the thyroid gland, both in the right and left lobe, is increased, and overall activity is of 5.3%. Normal is in between the range of 0.2 to 2%. This is a case of Graves' disease, Graves' thyrotoxicosis. When you talk about Graves' disease, it demonstrates diffuse, markedly elevated uptake on both I-123 and technetium-99 scans. They cause about 70% of cases with thyrotoxicosis. And as I mentioned, it can be diagnosed on both these isotope studies. And what about being in the nuclear medicine department, we are also in a position to treat this with radioactive iodine therapy. We use I-131 therapy, and the dosage is in between 6 and 30 millicuries. I-131 dosimetry can also be done on the basis of the weight of the gland, wherein you take the weight of the gland and multiply with 100 microcurie and give that as the ablative dose for thyrotoxicosis. How about thyroid cancer? The most common form of thyroid cancers, as you know, are papillary and follicular cancers. Metastasis can be seen regionally in the neck, distally, most commonly in lungs and bones. Medullary thyroid cancer, anaplastic, and Hürthle cell variants of cancer are less likely to concentrate iodine. Again, the dosimetry of thyroid cancer can be both on clinical need basis and on the basis of activity on I-123 uptake scan. The treatment is usually in the range of 100 to 200 millicurie. It can be given in multiple settings or one setting. Let's take a few examples of I-123 iodine scans. This is a whole body I-123 iodine scan. You can see that there is increased activity in the thyroid bed and multiple foci, both in the neck, mediastinum, and what looks like spine and the bony pelvis. This is a metastatic thyroid cancer with increased activity on I-123 scan. This is a fused SPECT-CT image demonstrating multiple foci of uptake in relation to the bones. What is the role of PET-CT in thyroid cancer? So let's identify this. For differentiated cancers, I-123 is the best imaging modality. For dedifferentiated thyroid cancers, F18 FDG has increased role. When the thyroglobulin level is greater than 10 nanograms per ml and in a setting of negative I-123 scan, FDG PET-CT is extremely useful for thyroid cancers. It is useful to identify both recurrence and metastatic disease, and it has high prognostic value. PET-CT sensitivity is almost 72% when the thyroglobulin level is greater than 10 nanograms per ml, and the PET-CT specificity is almost 95% in cases of both recurrent and metastatic cancer. How about medullary thyroid cancer? PET-CT can also be positive in medullary thyroid cancer, particularly if calcitonin is above 1000 picograms per ml. In terms of medullary thyroid cancer, due to its neuroendocrine differentiation, DOTA-TATE PET-CT is more sensitive than FDG, and even dopamine PET-CT is extremely sensitive in this setting. I'll show you a few examples. So this is a case of thyroid cancer post-therapy, and you're looking for a recurrence. You have a whole body I-123 scan. There is this physiological activity in relation to the stomach, bowel, and urinary bladder. There is no significant activity elsewhere, nothing striking in relation to the thorax or in relation to the bones. But if you look at this case, subsequently, when an FDG PET-CT was done, you see multiple foci of uptake in relation to the thorax, and these are multiple nodules, and this is just one example of this. This was a patient with negative iodine 123 scan and elevated thyroglobulin, and these are FDG positive lung metastasis in a patient with thyroid cancer. So looking at the sensitivity of FDG PET-CT, let me also give you one more example. This is a patient of 67-year-old post-operative papillary thyroid cancer with rising thyroglobulin and negative whole body iodine 123 scan. So this was the FDG PET-CT scan. I'm just showing you the scanogram here to see, do you see any activity in the region of the neck? The answer is no. But if you look at the same patient subsequently after stimulation with recombinant TSH, it shows increased activity in thyroid bed, and this was the level of recurrence. So in almost 6 to 10% of cases, you can improve the sensitivity by either thyroid hormone withdrawal or recombinant TSH administration, and thyrogen administration seems to be more easier in terms of workflow and patient convenience. Let's look at another case example. This is a patient of 45-year-old with papillary thyroid cancer, 5 years status post-thyroidectomy and radioactive iodine ablation. Now the patient comes with hoarseness of voice and rising thyroglobulin levels. And I can tell you that this patient had a negative I-131 scan. And so what is the clinical differentials? We're looking either at an interval new head and neck cancer or a metastatic dedifferentiated thyroid cancer. So this is an example of where you have a negative iodine scan and a positive FDG scan. So as I said, this patient is status negative iodine scan post thyroidectomy. You can see the clips around the trachea. There is no activity or soft tissue abnormality definitive around the tracheal region or thyroid bed. And this is the negative iodine scan we talked about. But when you did an FDG PET scan, there is a focal area of increased activity almost at the level of the glottis in the left vocal cord, with some increased soft tissue density and heterogeneity and ossification. And another focus of uptake in relation to the left lateral aspect of sternum. And this was at least 2 foci of uptake, and this was metastatic disease from thyroid cancer. Let's look at another example of a negative FDG and a positive iodine scan. This patient probably did not follow the workflow as deemed appropriate, and the requesting physician jumped into getting an FDG PET scan rather than getting an iodine scan. And when you look at the FDG PET scan, you can see that there is no definitive focus of activity either in the region of the thyroid or in the region of distant bones or lungs. But when this patient had a subsequent iodine scan due to persistent elevated thyroglobulin, this shows increased activity in the region of the right pelvis. And on a SPECT CT image, you can see that the activity is co-registered around the level of right ischium, and this was the level of bony metastatic disease. The activity you're seeing in the pelvis here is secondary to the retention in the urinary bladder. But this patient had only bony metastatic disease, and this was positive on an iodine scan, but negative on an FDG scan. Because PET-CT is now being done for almost every cancer, and you're going to be seeing this in routine clinical practice, you will incidentally find both diffuse and focal areas of uptake in relation to thyroid gland. So when you see diffuse activity across the thyroid gland in an example like this is usually an example of thyroiditis. But when you see a focal area of activity in relation to thyroid gland, like in this left lobe, this is usually a synchronous thyroid malignancy until proven otherwise. I mentioned about dotatate PET-CT. This is extremely useful, particularly in cases of neuroendocrine differentiation or medullary carcinoma of thyroid. Very quickly, let's go through some pitfalls. A cold nodule of on thyroid scan has increased malignant incidence. Focal thyroid FDG uptake usually needs workup or subsequent biopsy to exclude a synchronous thyroid malignancy. Diffuse thyroid FDG uptake is usually benign and related to thyroiditis. If you have low-grade papillary and follicular cancers, these are usually radioiodine avid and FDG non-avid, whereas a high-grade papillary and alloplastic tumors are radioiodine non-avid and FDG avid. So as I mentioned, negative iodine scan and a positive FDG scan demonstrate tumor dedifferentiation. And medullary thyroid cancers can be seen on FDG and dotatate, but better visualized on dotatate and dopamine scan. Right, going to parathyroid imaging, different modalities such as ultrasound, nuclear medicine, MIBI, and 4D CT are used. Technetium MIBI usually focuses on mitochondrial binding, and with SPECT CT, it has a sensitivity of 80% and specificity of 71%. What are the pitfalls? The nuclear medicine MIBI imaging is not specific to parathyroid adenoma. It can be seen on both parathyroid carcinoma and metastatic disease. You can occasionally see ectopic adenomas, as in parathyroid adenomas, from at any level in between carotid sheath to lower mediastinum. If you have a small adenoma less than 1.4 ml, they can be false negative. Sometimes you can have a false positive uptake due to thyroid adenomas. and sometimes mimics due to swallowed thyroid activity may also be confusing with an adenoma. Let's look at a few case examples of how parathyroid imaging looks like. This is what we normally do. We do an immediate image and a delayed 2-hour image. So on an immediate image, you have uniform thyroid activity and if additional parathyroid activity. And on a 2-hour image, the thyroid activity washes out. And if there was a parathyroid activity, that would be left behind. And let's look at this example. You have a thyroid activity, which is the background, and a parathyroid activity, which is intense focal uptake in relation to the left superior pole. On a delayed image, there is a persistence of this activity, and this is the site of parathyroid adenoma confirmed on a SPECT CT image on this particular case, left superior pole. Let's look at another example. We have an ultrasound case example showing a hypoechoic gland, usually quite classic of a parathyroid adenoma. And when you do maybe imaging, it shows an early and delayed imaging. There is a retention of activity in relation to the right lower pole, and this is the site of parathyroid adenoma. Again, confirmed on the SPECT CT imaging. You can see posterior to the thyroid gland, which is dense, you have a hyperdense abnormality, and this is the parathyroid adenoma. What about this case? In the you have almost 2 foci of activities. You have one in relation to the right superior pole and one in relation to the left inferior pole. This is a case of double parathyroid adenoma. Could one of them be a hyperplasia? And the answer is yes, but in this particular case, it was biopsy confirmed parathyroid adenomas. So let's look at this case of hyperparathyroidism and a negative ultrasound scan to identify where we can find the parathyroid adenoma. You can see that there is a subtle area of increased activity seen posteriorly in the anterosuperior mediastinum in the prevertebral region. This is a very subtle area of uptake which was localized on the SPECT CT. But you can see it on multiple images, and our suspicion was quite strong. So we suggested a 4D CT as a secondary modality to identify this particular gland. And you can see here in the tracheoesophageal groove medial to the esophagus, you can see a hyper-enhancing gland just here measuring about 0.5 centimeters. And you can see a long ovoid hypervascular nodule, and this was confirmed to be the ectopic parathyroid adenoma in this case. How about parathyroid adenomas on FDGs? These can be seen in FDG both in adenomas or in malignant cases, and we see this routinely because we do a lot of oncological imaging, and this was a case of confirmed parathyroid adenoma subsequently when the patient was evaluated for biochemically and post-surgically. PET CT with fluorocholine is more sensitive for PET CT, and this is almost becoming a one-stop imaging in our institution, and I'll explain why. This is extremely sensitive. You can identify subtle, tiny parathyroid adenomas, like in this case, and it is in the prevertebral location here to the left of midline. They have a sensitivity of 93.7%. They work on the principle of biosynthesis in the cell membrane phospholipids. They have excellent detection and localization rate. They have a shorter acquisition time. Post-injection, within 10 minutes, the scan is done, and you can identify exactly the number of adenomas and the location of parathyroid adenoma, if it is ectopic or not ectopic. It has a lower radiation dose, and you can almost do a one-stop shop imaging. You can do an ultrasound scan, and then you have if the gland is of a small size, you can jump into a fluorocholine PET CT, and if the gland is of a big size, you can do a SPECT maybe localization. Let's look at an example of a status post-thyroidectomy with elevated parathormone, and this was not picked up on both SPECT CT imaging and on ultrasound, and you can see that there is a subtle soft tissue density with increased uptake on this fluorocholine PET CT, and this is in the anterosuperior mediastinum. This is another patient, a 19-year-old with generalized pain and hyperparathyroidism. As you can see, this was a SPECT with MIBI, and you can pick up this parathyroid adenoma in the anterosuperior mediastinum at this location here. but also what was seen was this non-specific focus of activity in relation to the right chest wall. And you can see on the bony windows that there is mild expansion of the bone with a lucent component. So this is a case of hyperparathyroidism with a brown tumor. And if we moved on and repeated the and fluorocholine PET CT of the whole body to see how many of these brown tumors you can see. And as I said, not only can we identify the parathyroid adenoma, in this case, there are multiple bone lesions. All of these were subsequently confirmed as brown tumors. This is just a quick, good example of a patient who has a hyperparathyroidism with parathyroid adenoma, a pituitary tumor, and also a pancreatic lesion. And this was a patient with MEN1 tumor. These are my references, and I'm happy to take any questions. Thank you.
Thank you so much. Thank you so much, Dr. Hidayat, for this excellent lecture. So I invite all the speakers for the Q&A session. And to start up, we have Dr. Ansari. We are waiting for Nada, and Dr. Fawziya also joined us. So we can start. So Dr. Fawziya, I will just have one question for you. Do you think that one of the issues is that we don't have a population-specific cutoff or references for us? So we are using the manufacturer references. So we are facing lots of patients, for example, are referred just for borderline low free T4, which we face it for our Roche assay. So what is your say in that?
Yeah, I agree with you, Dr. Ria, actually, because most of the time, with the increasing sensitivity of the assays, we are having frequent issues with isolated hypothyroxanemia rather than hyperthyroxanemia. And we have raised this to our lab, and they just come up with the same answer, that they followed the reference range given by the providers. And in query regarding the interfering antibodies or all the other factors, usually they don't come up with an answer for us. So I really look forward that if we come across any study or population-based reference range across the UAE, which may in future change the T4 reference range. I agree with you. This is a very increasing problem, actually, and which give rise to a lot of unnecessary investigation also.
Absolutely, absolutely. Hopefully we'll have one multicentric. I know that there is one already done for references in trimesteric pregnancy in Abu Dhabi. But population one, I'm not sure if it is still conducted or not. And then Dr. Ansari, you just mentioned regarding the predictors size of the adenoma as a possible predictor of the diagnostic accuracy in adenoma, I mean parathyroid. So if it is low, it may, small, it may lead to false negative in systemic scan, while maybe it is detected in choline PET. So what about BTH, biochemical predictors? Are there any biochemical predictors that could direct us whether after ultrasound we go to choline or we go to systemic B?
I don't think so. I think biochemically there is a very strong evidence of primary hyperparathyroidism. And then when we have done systemic B scans, we have picked up about 7 out of 10 of these cases, and in about 2 or 3 we are struggling to find the parathyroid adenoma because it's either too small or hidden in the posterior aspect of the prevertebral soft tissues. And despite our SPECT CT sensitivity, we have failed to identify this. And when we tried in some patients with choline, and I started the choline service almost a year ago, we have done about 32 scans, and I have 30 of them are positive. So that is the kind of sensitivity I'm having with choline versus the sensitivity with maybe scan. So we have known this for a while, but then there are many reasons, insurance reasons, cost reasons, and practicality reasons, and we feel that we cannot do both these scans in all these patients, and that's why particularly if you do not see the gland on ultrasound, or if the gland is small, I have figured out that my pickup rate is going to be better with choline scan, but and that's why I'm trying to triage them in a way so that I can justify to the insurance teams that we are not doing at the full spectrum of 4D CT maybe and choline on all these patients. I'm trying to do some of them through the route of maybe and some through the route of choline so that they can approve this.
Amazing. I think this is a very good thing. So we have to be, it is like a precision medicine where we have to pick the right imaging for the right patient.
Yeah. And that's why in some cases, if I may add, it's always good to have a complementary imaging modality, whether it's an ultrasound, whether it is biochemical, or more importantly, a 4D CT, so that it improves the diagnostic accuracy and the confidence for the surgeon before he goes in for minimal invasive parathyroidectomy.
Absolutely. Many surgeons actually, they do prefer to localizing methodology in terms of imaging. Excellent. So Dr. Ananda, there is a question in the Q&A regarding the radiofrequency ablation for multinodular goiter in older people who have comorbidities, and there is a contraindication for the surgery. Is there a role for thyroid ablation in such patients?
Yes, I think this is one of the good candidates. Like if patients have contraindications for surgery, first we need to make sure that there is no any question about cancer in this nodule, and then like ablating 2 or more of nodule by radiofrequency ablation within 1 session appear to be offer comparable level of safety and efficacy to than one single. The most important thing is that we make sure that there is no any pacemaker, no any contraindications, there is no any nodule which attached to the vital organ like vessels or esophagus. So then there is no any contraindication. The age by itself is not contraindication if the patient is able to tolerate. And nowadays for radiofrequency ablation, we have different devices, like they update it. Like before we have the monopolar, and now we have bipolar, which it is even like can be applied for pregnancy. But in our hospital, we don't do that. Like still, like we don't have any patients with but it's mentioned in case report, and yes, it's safer, and I think yes, we can try it. Why not?
Again, for you, Dr. Ananda, there are several questions regarding the different modalities for thyroid ablation. They did took, I think, 2 of the attendees, they mentioned that in the guidelines, they do recommend first-line laser and radiofrequency ablation. However, what is the what are the criteria to select which and which, whether radiofrequency laser or microwave ablation? Because I think you mentioned one of the cases have the microwave ablation. So is there any choice or predictors you will choose this one or this one over this one?
Yeah, actually, that's also good questions, because we don't have clear like comparisons, like in certain nodules, like this can work better than the other, but as in complications, maybe as we say, like more in microwave ablation. So if we will think about some of solid nodule, maybe I will go more with laser and radiofrequency. Because more solid, that mean it less, maybe the efficacy will be less in case of volume reduction. So that I will choose more radiofrequency ablation or laser other than microwave. But again, it's a decision of the intervention radiologist more. Sometimes we go and discuss with him, but we can use any of it's based on the patients. There is nothing in the guidelines like mentioning is one favor the others or in any of the review.
Excellent. Dr. Fawzia, there is a question regarding oncology patient who are on TKI or in immune checkpoint inhibitors. How frequent would you screen and monitor for thyroid function test?
So as per the latest guideline, they have come across because of the increasing frequency of endocrinopathy associated with the checkpoint inhibitors, that there are certain drugs which have propensity more for the primary hypothyroid or hyperthyroid rarely, along with the hypophysitis. So baseline screening is recommended for all those patients who are going to have immune checkpoint inhibitors. And as per the baseline results, follow the symptom scores. And if patient develop anytime any red flag sign of hypothyroid or hyperthyroid, then it is recommended to follow the results. And based on the results, the recommendation is for treatment of hypothyroidism. Regarding the checkpoint inhibitors, because it directly inhibits the thyroid function and synthesis at the level of thyroid gland. So, of course, all the patients should get a baseline screening for thyroid function test, and very close monitoring is required clinically as well as the biochemically for those patients. There is no fixed periodic follow-up is given, whether to do is 3 monthly, 4 weekly, or 6 weekly for the follow-up labs. All the guidelines suggest to follow the clinical status of the patient and keep a very low threshold for repeating of the tests.
I think also it depends on the center. For example, the oncology center in Tawam, all immune checkpoint inhibitor patients, they will have baseline before each cycle, thyroid function and cortisol. So, and this is depends on the visibility of the service and availability.
Availability, definitely.
Yeah. Excellent. I think there is also another question for you, Dr. Nada. Is there a role for thyroid ablation in a patient with malignancy, thyroid malignancy?
Yeah, this is other good questions. My talk is today concentrate about the benign nodule. Yes, there is a role and there is increased evidence in this field, but in our hospital, we do not do that for any malignant case. So we do it only, we restrict for the benign until any clear, more evidence in the guidelines about it.
I think with more expertise, maybe it will be used in selected cases, hopefully. Dr. Ansari, you mentioned regarding the uptake scan, thyroid, and in graphics where it shows diffuse uptake. However, sometimes we get confused between patients who ended up having asymmetric unilateral uptake, and for example, and they are mislabeled as hot nodule. So whether the patient have a hot nodule or asymmetric uptake in graves, any way to differentiate between them in the uptake scan with the contralateral uptake?
It's a very good question. I think what is important is the kind of multimodality imaging in this case. You have an ultrasound and you have a nuclear medicine scan which shows the pattern. You can put these two things together. Or if you have a nuclear medicine scan and they have done a SPECT CT at the same time, in which they have a CT component which shows the thyroid gland, the size, the volume, the attenuation, and the nodules versus cystic changes. When you put these two information together, the anatomic information, whether you're getting it from a SPECT CT of a CT image or from an ultrasound image and the nuclear medicine image, that's when we can get more diagnostic confidence by saying that whether this is a true nodule or a small volume gland versus calling it a false positive nodule.
Absolutely. Final question for maybe all of you, maybe specifically to Dr. Nada and Dr. Ansari, since it is around your topic. So patient who receive thyroid ablation, one of the issues that we need to be aware that their ultrasound characteristics of their nodule will change and become as if suspicious. And they will be, for example, upgraded in thyroid. So maybe they will be labeled as thyroid 5. After post-ablation because of the changes that will happen. So do you have any comment on that, Dr. Ansari?
So no, I think we just do the follow-up in terms of 1 month, 3 months, and 5 months, and then review it in the MDT based on the TFTs. And
Dr. Nada, are there any studies regarding changes of pathology after radioiodine? Thyroid ablation?
Changing pathology.
Yes.
Like there is certain change in the ultrasound features, which we can see it like white dots, and we need to be familiar with it. So then, but with the time, like 3 months and 6 months, those change will disappear. For pathology change, no, I don't aware about any change, or it came through my across during my readings about changes.
Thank you so much for all of you. There, I think, still remain some questions. If you can just answer them in the Q&A. Thank you so much for your lectures and for being with us in the Q&A. And then we have to move to the Servier sponsor talk. And the talk will be around cardiovascular safety of sulfonylureas in type 2 diabetes, which is sponsored by Servier, who are supporting our this educational activity. And our speaker is Dr. Osama Barakat, who is a consultant in diabetes and endocrinology, as well as general medicine from Burjeel Day Surgery Center, Abu Dhabi. The mic is you, Dr. Osama. You can start your presentation.
Thank you very much, Ray. Thank you. I was listening very interestingly to the talk about the thyroid. I tend not to use thyroid uptake scan because they're very confusing, even at my age. My talk will be really totally different. Let me just try and share my screen. 1 second, if I may. Can you see my talk now?
Yes, we do. Yes, we do.
Excellent. Now, my talk is slightly different. It's really about the cardiovascular safety, which is really now the hot topic in all diabetes management. Let me just start by sharing my disclosure. One thing really to mention in this meeting that, diabetes treatment might have changed from a perspective of the big influx of pharmacotherapy agents, but the principle of diabetes management hasn't really changed. It's all about still reduction in glycemic load, A1C, reduction in hypoglycemia, and certainly reducing complication, particularly the cardiorenal ones. Majority of the data we've seen since the EMPA-REG outcome, or even go back to the DDB4 inhibitor, the rosiglitazone problem, and so on, when the FDA made it mandatory that all these medications have to have some form of cardiovascular safety, and to our surprise, it came with a superiority, that all of these trials were based and done on the background of standard of care versus placebo with a standard of care, or versus the active arm, which is the new agent. But all these patients actually on sulfonylurea, on metformin, on insulin, on. Yeah, so we cannot treat diabetes today, particularly diabetes we have in the Gulf area and the MENA area, which is very heavily embedded with cardiovascular toxicity even prior to the disease showing. So we still use all the agents to treat diabetes, right? So here we start with this article published in Diabetes Care, very recent, 2023, about the cardiovascular safety in type 2 diabetes with sulfonylurea as a second-line drug. We know that it's still a very popular second-line drug, despite all the improvement and all the data coming from the cardiovascular outcome trials. This is a nationwide population-based comparative safety study, right? And here what they're looking for is, if you have a second line after metformin, be it a sulfonylurea versus DDB4 or TZDs, which one is better, which one is more safe as a second agent. And really the objective was to assess a real world cardiovascular safety of SUs in comparison with DDB4 inhibitor and TZDs. It is a nationwide retrospective population-based comparative study, and the sources were from the Scottish Care Information Diabetes National Register in 2018 was extracted from that register. The inclusion criteria were people with type 2 diabetes diagnosed in Scotland before 31st of December 2017 who failed to reach A1C below desirable range and initiated as a second line with the lowering agent after the 1st of January 2020. So it's a multivariable, it's a Cox proportional hazard regression, and instrumental variable approach were used to control confounding factor because it's retrospective study. So this is the method that was used, okay? And if you look at the final cohort, the final cohort for analysis included 29,500 patients. And if you look at the number of patients used sulfonylurea, we have 18,513. We have DDP4 inhibitor, 9,104. TZDs just below 2,000. And that's quite actually rational and similar to what happens in the United Kingdom. If you look at the sulfonylurea breakdown particularly, you see that diamicron or gliclazide MR was used in majority of the cases, 87.2%. So the bulk of the data derived from the SUs were really based from gliclazide. The primary outcome was the composite major adverse cardiovascular event, the 4-point MACE, including hospitalization for myocardial infarction, hospitalization for ischemic stroke, heart failure, and cardiovascular death. Each individual component of the composite and endpoint, as well as all-cause death, were analyzed as a secondary outcome. But remember, this is a retrospective analysis. If you look at the results, here you see the 4-point MACE for the SU versus non-SU treatment. You see that the SU showed pretty much a safe cardiovascular outcome when it came to the whole component. If you look at the individual component of the composite, hospitalization for MI or for stroke, you see that sulfonylurea versus the other showed pretty much, quite significant safety in those patient group. If you look for hospitalization for heart failure again, if you look at cardiovascular death, all-cause death, they were all showed that SUs were quite safe and favorable in this perspective. So in conclusion, really, if you look at the outcome, we know that SUs as second line for glucose lowering are unlikely to increase the cardiovascular risk or cause mortality. They're very cost effective. We know this because they're cheap and widely used and should remain part of diabetes treatment. We know this is the reality. So these findings confirm that a second-line sulfonylurea are unlikely to increase the cardiovascular risk or cardiovascular mortality, given the potent efficacy, microvascular benefit, and cost effectiveness. This study support that SUs should remain a part of the global diabetes treatment. We all go back to UKPDS, and we know that a reduction in A1C, even with the use of SUs at that time, showed reduction in microvascular complication. So here we have a fairly good and strict data from the Scottish National Registry showed that sulfonylurea, particularly diamicron, which is 87% patients were on, and that trial showed a significant safety in terms of cardiovascular mortality. So the summary is the whole nation study assessed the real-world cardiovascular safety for sulfonylurea in comparison to DDP4 inhibitor and TZDs through development of robust methodology for causal inference. Multivariable cause proportional hazard regression and instrumental variable approach were used to control confounding because it's respected in a similar way to the randomization process in RCTs. The study demonstrated that SUs as a second line is fairly safe, and those robust observational data extend recent trial data addressing this question. Because there's a lot of debate about SU and the cardiovascular. And here we come to the other trial, which is the GRADE study, which is the glycemic reduction in type 2 diabetes, microvascular and cardiovascular outcome, published in New England Journal of Medicine in 2022. And that's a comparative effectiveness of the commonly used glucose-lowering medication when added to metformin with respect to microvascular and cardiovascular disease outcome in patients with type 2 diabetes. That's the GRADE research group. And the methodology of the GRADE study was compare the effectiveness of the 4 commonly used glucose-lowering medication added to metformin when people not achieving A1C. It's a multicentral, it's randomized and para group with a 5-year follow-up. 5,000 participants, A1C at baseline 6.8 to 8.5, duration less than 10 years of diagnosis. The most commonly medication used, insulin, glargine, basal insulin, U100, glimepiride, very widely used sulfonylurea, liraglutide, and sitagliptin. Patient excluded who had a major cardiovascular event or advanced heart failure or have an eGFR below 30. So stage 4 CKD and below were excluded. Those are the medication we use with metformin. The primary outcome was the cumulative incidence of A1C below 7%. The secondary outcome was include again A1C level below 7.5, moderate and severe increased albuminuria, renal impairment, diabetic peripheral neuropathy, any cardiovascular disease, major adverse cardiovascular event, hospitalization for heart failure, death from cardiovascular causes. If you look at the metabolic failure or glycated A1C, you see a patient who were put on insulin with 26%, liraglutide 26, glimepiride 30%, and sitagliptin DDB4. So the cumulative incidence of A1C 7% differs significantly among those four groups, with a statistical significance of p-value less than 0.001. Rates with the glargine and liraglutide were similar and lower than those with glimepiride, sitagliptin. You expect this, right? Because of the potency of basal insulin and GLP-1. For participants with a higher base A1C levels, there appeared to be an even greater benefit with glargine and liraglutide and glimepiride when you compare DDP4 inhibitor. So certainly, if you had a higher A1C, then your insulin, glargine, glimepiride, liraglutide were more efficacious than a DDP4, because we know DDP4 inhibitor don't have that amount of glycemic reduction, but they're fairly safe to use. And if you look at the microvascular outcome in the GRACE study, you see there were no material differences among the intervention with respect of microvascular outcomes, which means the microvascular outcome will appear regardless of the second-line therapy you've used in order to achieve target. That's unlike what we have seen with macrovascular complication, where SGLT2 inhibitor and GLP-1 in particular, some human analog GLP-1 showed cardiovascular outcome. But here the microvascular outcome data did not differ between the four agents added to metformin. And therefore, we go back to UKPDS that a reduction in A1C will eventually produce a microvascular reduction. If you look at the macrovascular outcome, the treatment group did not differ with respect of MACE, heart failure, death from cardiovascular cause in all-cause death. So there was small differences with respect to rates at any cardiovascular disease, actually very minimal, because we don't expect those medications to produce benefit, but we know they are safe from previous trials. If you look at the adverse event, now certainly you will see more hypoglycemia, maybe with SUs and insulin, when you compare it to liraglutide and DDP4 inhibitor. That's probably unavoidable. So if you look at the conclusion from the GRACE study, so in this trial involving participants with type 2 diabetes of very brief duration, the incidence of microvascular complication, MACE, heart failure, hospitalization, and death were not materially different among the four treatment groups. The findings again indicate possible differences among the groups in the incidence of any cardiovascular diseases. Now, the major trial that brought gliclazide to light over other sulfonylurea, the advanced trial with its cardiovascular safety, where we had 11,000 patients with type 2 diabetes, and there was no increased risk of major macrovascular event with the intensive glycemic control with the gliclazide. If anything, we've seen reduction in nephropathy and some microvascular complication, but certainly the tight control with the gliclazide or modified release sulfonylurea showed no increased risk of macrovascular events. And if you even look at the Carolina study, the Carolina was slightly different. That was comparing linagliptin versus glimepiride, a widely used sulfonylurea in the United States, because diamicron is not licensed in the USA. Again, what we have seen that among patients with type 2 diabetes and elevated cardiovascular risk, the use of linagliptin compared with the glimepiride, so another DDP4 with glimepiride over a median of 6.3 years, resulted in non-inferior risk of composite cardiovascular outcome. So again, showing some safety signal, quite significant safety signal for another sulfonylurea. If you look at the TOSAC-IT study, and that's another interventional cardiovascular outcome study, which is really a treatment assessed with metformin plus sulfonylurea, which 50% of the patients were on gliclazide, 2% on glibenclamide, 48% on glimepiride versus metformin and plus pioglitazone as being another arm. So metformin SUs with different classes versus metformin glimepiride, with the primary composite outcome was the first occurrence of all-cause death, non-fatal MI, including silent MI, non-fatal stroke or urgent coronary vascularization. Again, you see here no differences between the two arms, showing again safety when you look at the arm composing of the metformin plus the major 3-sulfonylurea being used, with the gliclazide being around 50% of the patient. So really, if you look at the cardiovascular outcome data with sulfonylurea class, when you compare all-cause mortality with SUs using direct and indirect, we see gliclazide and glimepiride were associated with a lower risk of all-cause and cardiovascular-related mortality compared with the glibenclamide in particular. So if you look at both tables, you're looking at, particularly between the SUs for all-cause mortality or cardiovascular-related mortality, you see gliclazide and glimepiride showed more safety when you compare them with glibenclamide, and that's data being published again back in 2015. So in conclusion, I'm sorry if I take a long time, SUs remain a major and safe player in type 2 diabetes therapy. There are some differences in the class itself. Gliclazide, particularly gliclazide modified release, is unlikely to increase cardiovascular risk or all-cause mortality, and gliclazide showed reduction in microvascular complication in different trials and comparative trials. With this, I would like to thank you very much. I'm more than happy to take any questions if you have any.
Thank you so much, Dr. Osama. I think we don't have questions, but I can just ask one. So any data on patients who already had established cardiovascular disease?
I mean, now, as I mentioned, right, if you look at, take EMPA-REG in particular, right, where 99% of the patient had cardiovascular event, right? Well, if you look at the analysis of the patient, over 35% of the patient was sulfonylurea in both groups, right? If you look at the advanced trial itself, a major part of those patients did have cardiovascular disease and microvascular disease. And when it showed eventually in the advanced trial that it's safe in terms of macrovascular, and it showed benefit in terms of reduction, particularly in nephropathy and retinopathy.
Amazing. Thank you so much, Dr. Osama.
My pleasure.
One more question. Thank you so much.
Thank you very much. Assalamu alaikum.
Wa alaikum assalam wa rahmatullah. So now we reached the end of this webinar. Thanks for you all who attend with us. You will receive, or you will do the evaluation, and hopefully within the coming 4 weeks you will receive the CME certificates, and you will register the email that you registered with for the webinar after filling the evaluation form. The webinar also will be available on demand on the EDAS Institute website. Also, it is in YouTube channel, so for those who missed some of the talks can go back and watch them. If you are interested to attend more of the coming webinars, please join the website of the Emirates Diabetes Endocrine Society for the upcoming webinars. And thanks again for Servier for their sponsor of this educational activity. Thanks for all our speakers, and hopefully to see you in future webinars. Thanks a lot.